Counselor No Fire, would you please lead us in prayer to start our meeting?
Heavenly Father, we just thank you for the day. Thank you for all your many blessings. Thank you for your traveling all of our people here safely, and we pray that they return back to work safely and to their families safely today. We pray that your will be done here today in the council chambers, and bless it to everyone here. In your name we pray. Amen.
Okay, Shelley, would you like to do the invocation, please?
Yes, ma'am. Mary Baker Shaw,
Ani?
Mike Dobbins, Keith Austin, Harley Buzzard, Joe Bird, Julia Coates, Sean Crittenden, Joe Deere, Kanan Duncan, Rex Jordan, Daryl Legg, Wes Snowfire,
Ani.
Dora Petzkowski, Mike Shambaugh, E.O. Smith, Janice Taylor, Victoria Vesquez. We have a quorum.
Thank you. Now for the approval of the minutes. Has everybody read the minutes? So moved. Do I have a second? Okay. Everybody in favor, say aye. Aye. Okay. Reports. First up is Mr. George Velour. Get the name right. It's my last meeting and I get the name right, right? Do it again. Valier? Still not getting it right. Good morning, George. How are you today? Good. I'm glad you're here with us, George. How are things going up in Claremore?
Things are going well. Today in the hospital, we had 9 inpatients. 6 of those were positive COVID cases. 4 of those were in ICU, and 2 of those were on ventilators. Our vaccinations are staying steady at about 30 to 35 a day. We're testing between 80 and 100 a day out in our drive-through, and we're averaging right now. We've got a 25% positivity rate. As far as I know, as far as I've been told, we're not having a lot of difficulty transferring patients, but I think most of them we're just admitting and keeping there. Patient encounters, dental is continually rising. We're up to 417 patients, providing just over 3,300 services for the month. We did just over 1,900 patients in lab. Pharmacy filled, the outpatient pharmacy filled 31,100 prescriptions. We mailed out just over 10,000 for the month. And in radiology, we provided just over almost 2,500 services to almost 2,500 patients for the month. Collections continue to rise and do well. The big, as with everybody, the big concern and the big focus is on taking care of our COVID patients there. We do have some that are out. It's actually started to hit some of our staff. We have some staff out that have tested positive, but we're still maintaining services.
George, do you know how many of those that have tested positive are, is it the Delta variant?
I don't, they didn't break that down for me.
Very good. Wow, what a report. Anyone have any questions? Yes, Counselor Dobbins.
George, how many hospital beds do you have?
36.
And how many of those are ICU?
6.
6. So are they all occupied now?
Well, actually, we cut it down to 4, so that we could space them out. But yes, it's full right now. We've been on ICU divert now for several weeks.
Did you mention that you do have some ventilators being used right now?
Yes, we've got 2 on vents right now.
How many? Is that all you have? Is 2 ventilators?
No, I think we have either 6 or 9.
Okay. All right. What is your surge plan capacity?
Well, You know, when we first started this, the governor wanted everybody to try to increase capacity. What we found is we had trouble finding nursing staff to staff that extra 25%. So we're looking at maintaining a complete staff for those 36 beds.
Well, I know staffing's a challenge,
It is.
big-time challenge. So what testing are you offering to the public? Are you still offering testing to the public?
Yes, we have drive-through COVID out front. You don't have to make an appointment, but they like that. But you can just drive up and get tested out front.
Yeah, okay. All right. Thank you, George.
Yes.
Thank you, Madam Chair.
Counselor Buzzard?
Well, George, today is my last day, so
Yes, sir.
enjoyed working with you. I told you that last month, but we had another council. But anyway, it has been a pleasure. I think you've done a good job at Claremore Hospital for our service unit there. The other question I had is on vaccination from 12-year-olds and older. Are you getting many of those patients in?
Not as many as we had hoped for. We received the vaccine right at the last week of school in the school term in the spring or in the summer. And we had hoped that we would get a lot more, but it hasn't, the response hasn't been what we had hoped for.
Does the Claremore Service Unit have, I guess, public health nurses that go out into communities anymore and that does anything like that?
Well, the nation took over the public health nursing
Yeah,
program.
uh-huh.
Now, but even with that said, the nurses that are there do a fantastic job for us. Whatever we need, they
do?
take care of it.
Okay.
Yes, they're outstanding.
Okay, well, that's good to know.
Yes.
Thank you, sir.
Yeah,
Thank you.
thank you.
Counselor Coates?
I have a little bit of follow-up to Counselor Buzzard. So not only the children over 12, but the ones under 12. Are you seeing very many children coming in and being hospitalized at this time, or an increase over in the past, or what is the,
I don't know that we've seen any under 12.
okay. All right, that's good, because my understanding is that this is much more transmissible, and it does hit
It
them
is.
much harder than the original version did, so, thank you.
You're welcome.
Counselor Crittenton?
Yeah, George, you know, we hear beds available and different talk about beds. Now, what staff goes with that bed, or the staff that's needed when, you know, the public hears, well, there's 3 beds here, but just generally speaking, the amount of staff that goes with that one bed?
Yes, sir. You need RNs, we need nurse aides out there on the inpatient side. And along with that, you need respiratory therapists, all the ancillary services, X-ray, lab, to go along with that. But where we're running into the need is on the nursing side. These agencies come in and hire nurses and offer them huge bonuses. So far, we've been lucky, we haven't lost any, but we haven't been able to find nurses, and the price of an agency nurse is just through the roof. So that's our biggest, nursing is our biggest need.
Okay. So George, like, you know, the shifts you see, you know, covering an ICU shift, like that particular nurse, how many different rooms can the one shift take care of? Is kind of what we're doing, the 3 or 4?
Well, now on the floor, I know they try to keep it at 1 RN per 5, under normal conditions, for 5 patients, plus your nurse aides and LPNs that go along with that. I'm not really sure if they stayed at that staffing plan or not. Under COVID, that may require some more intensive care. And then on the ICU part, I'm not sure what their staffing plan is in ICU. I can find out for you.
Okay.
Be
Well,
happy to.
Generally speaking, I'd be interested, you know,
Sure.
nationwide, kind of the
Okay.
general numbers. Thank you, George.
You bet.
Thank you, Chair.
Thank you. Anyone else with questions for Mr. Valier? George, I noticed here that your newborns are 33.3%. Are these COVID babies?
Some,
You wouldn't know?
not for sure.
I mean, people were home for a long
They
time.
were,
last,
and that number really hasn't dropped a lot. We're continuing to have
Yeah.
babies.
Yeah. Well, hopefully the COVID numbers will go down and the babies will still go up.
Yes.
That's how I see it.
Yes.
So, anyway, listen, thank you so much. For the past 4 years, I have sat here and you have showed up, and I'm so grateful. It's truly been a pleasure. Thank you again.
Thank you so much.
Okay, next up, we've got Mr. Jones. Excuse me, Dr. Jones. Correct myself. Good afternoon, Dr. Jones. How are you?
Very good. Good afternoon. All right. Would you like me to go ahead and get started?
Please.
All right. So you have the report in your packet. I'm not going to spend a lot of time on the report today. I have other things to report to you, but the report shows things are stabilized as far as contract health and our vacancy rate as far as field positions when it comes to our providers. And those are things that we typically look at each month. But I want to get on to talking about COVID and how it's affecting us. So if you don't mind, I'll spend some time on that, and then we can come back to any questions that you might have about the report. So the numbers are increasing, as we all know, and you can see that anecdotally in your communities. I just want to talk about different aspects of COVID, and we're going to start about testing. So we are increasing our testing capacity. We've seen a huge increase in testing requests in the last 2 weeks. So we've opened up all of our drive-throughs back up at all of our clinics. They're from 8 to 4. If they're, for some reason, due to weather or maybe the temperature gets too hot and we have to pull the staff in because our air conditioners aren't keeping up and things of that nature, you can still get the testing done. Just come up to curbside, and they'll have signs there that tell you how to do that, and we'll come out to the car and test. So that is available 8 to 4 every day. And then on the weekends, we have drive-through available right outside of the hospital from 8 to noon, and then after that, it's in the urgent care and ER. Okay. And who we're testing, I know I get that question a lot. Anybody that's a beneficiary can be tested. Anybody that lives in the household with a beneficiary can be tested. Anybody that's a close contact that's sent to us from public health can be tested. We're not opening it up to everyone, but we are opening it up to a very broad spectrum of people to be tested. Okay, and those tests will be resulted back on their portal as quickly as we can get them reported. Typically, it's within a few hours. Okay. There is a COVID hotline. I know you guys are all aware of that, but I'll read the number just in case. It's 1-539-234-4030. And that will go to an answering machine right now because it is quite a bit of calls coming in. We are working on getting staff where we will staff it. We were at the beginning staffing it with people, and then the usage of it got so low that we turned it over to where it would collect the information and we would call people back. We're in that phase right now of transitioning back to having a live person on that call. So, but that number is available for anyone who has questions, COVID questions. Okay. Let's talk a little bit about vaccines. Our vaccine count right now is 69,180. The Oklahoma numbers are around 40%. Our Cherokee Nation employee numbers are a little over 70%, so we're very proud that inside of Cherokee Nation we've done a good job at getting the message out and then our people getting vaccinated, those that can. We're still struggling out in the communities with vaccine acceptance, but with this last surge we've seen an uptick where those numbers are going up quite a bit. You have two choices on vaccine. You can come walk in at any of our clinics between 8 and I think 3:30, because there is a time period where we have to watch you after you have the vaccine. So and if you get there between 3:30 and 4, we're still going to give you the vaccine. But you can walk in or you can call our vaccine hotline, which is 1-539-234-4099. And that number will get you to a scheduler, and you can schedule your time to come in and get the vaccine. And we do run very close, if not right on time. So a lot of times we're ready for you when you walk in the door. So that's if you want to maximize your time in and out, then that'd be the way to do it. Okay. The other thing that we're doing, we have a monoclonal antibody clinic. So as soon as we determine someone is positive, it triggers a phone call that you get from our staff and offer monoclonal antibody. And that is an infusion process. We're doing that 6 days a week, and we're doing about 20 to 24 a day. And that's to keep people, honestly, to keep people out of the hospital. We found that if you do that, and it reduces the amount of time it takes to recover. So we feel like that's a necessary thing to help keep our hospital beds available for those that are really in need of it. That gives me a segue into the hospital. So our hospital current numbers are, in a normal situation, we would have 25 med-surg beds. We would have 6 ICU beds and 3 step-down beds. Now, this doesn't include labor and delivery. We have another 18 or 19 beds in labor and delivery that we're not including in this number. Currently, we've upped that number to, our ICU beds are up to 14, and our step-down beds are up to 4. And as we sit here right now, our hospital's full. We have 6 patients waiting in ER, waiting for a bed, and are waiting to be transferred. And we have no place to go with them. We made 40 phone calls to 40 different hospitals looking for a place to transfer, and we don't have a place to transfer. So it's real, it's out there, it's propagating in our communities very quickly, and unfortunately, it's filling our hospitals. I don't know how else we can impact that. The problem is when we have situations like this where COVID takes over and fills our hospital, if you were to have a heart attack or a car wreck or some other thing that would put you in the hospital, there's no beds. There's no beds. You can't take a person out of the hospital to put another person in. So I can't emphasize how important the vaccine is at this point in time. So a little bit of numbers just to kind of tell you how the vaccine works. I did the numbers this morning. 95% of the people that are in the hospital right now with COVID are not vaccinated in our hospital. So let that sink in a little bit. That's how many people we're treating right now that are not vaccinated. And we have the highest number that I've seen for COVID only at 24 right now in the hospital. And we have 3 ventilators running. So with all this and the fact that we've had to initiate our surge plan and pull people around, of course, the hospital is our high acuity and our main priority. Then we have outpatient clinics and then ancillary services. So we've started pulling back on some of our services. We made the decision to pull back on elective surgeries, which are surgeries that can be scheduled that aren't emergent. So that if you did have a surgery and you needed a bed, we'd have a bed available for you. We don't right now. So we pulled that back, and we're utilizing that staff in other areas. We also pulled back dental services to emergency care and children only. We're doing that right now. We're evaluating these things on 2 weeks at a time. So every 2 weeks, we're evaluating where we're at and deciding whether we extend it 2 weeks or we open our services back up. The idea is that we're pulling back those dental staff that are licensed to be able to free up nurses in testing, vaccine, places where nurses are used to document. We're using our dental folks to do that so that those nurses can go work in the hospital. That's the only thing we can do right now. I think George alluded to the fact that these staffing agencies are like headhunters. They're stealing employees right and left. So we're doing all we can to keep ours. and make do where we can. We've also closed Marcoma Gym temporarily, and again, those staff were pulled back to help with contact tracing as we try to contract and get people off the street that are exposed. There are other services that we have in line to pull back if this surge continues to go, but we haven't got to that point yet. We're going to try we start this plan tomorrow, and then we'll see where we go and decide how much more we need to pull back. As a result, because we are pulling nurses from some of the outlying clinics to come and help in the hospital, you're going to see more telemedicine visits starting to occur. We're going to head back into that phase a little bit to free up some of those nurses to help us with the more high acuity patients. Another resource that we tapped into that showed up today is a critical care team from IHS that are here, and they have some support personnel, and they also have some people that are going to come in and make sure that we're being as efficient as we possibly can. We feel like we are, but it's always good to have another set of eyes look at us and see if there's anything we can do better. So they arrived today, and they'll be with us for a few days to evaluate all the places that we're trying to be as efficient as possible. Other than that, I'm going to leave on a good note, or finish my oral report on a good note. It is National Health Clinic Week, so at all of our clinics we are recognizing employees, doing drawings. We had planned on doing some feeding the employees and doing some luncheons, but of course with this surge we can't get together and eat, so we are still doing individually wrapped foods, and we have individual preparers for their meals, and we're going to provide some meals this week. So same thing as Hospital Week, it's just for outlying clinics. So just if you get a chance to say thank you to some of our clinic staff and some of our administration team, be a good week to do that. So that's all I have.
Thank you, Dr. Jones. I think some of our counselors have some questions.
Okay.
Counselor Crittenton.
Yeah, a comment, then a quick question. Saturday, 6 o'clock in the morning, we won't go into names or even the situation, but Counselor Duncan and I received a call, and Steve Carey, Dr. Jones, and the chief fixed a problem for one Cherokee on a Saturday, and that hit me good, Doctor. So thank you, and that's what it's all about. And there's lots of good things going on, but it really hit home to me Saturday. So thank you, and your staff. I'm sure there was a lot more people involved, but the players I named, Mr. Carey, you, and Chief Kanan, it was a good deal. So thank you again.
My pleasure. We had a situation that, again, we won't talk about names, but it was a bad situation for the family and for the patient, and we got a solution. It took a little while, but we found a solution. So
Thank you.
Okay, Counselor Duncan.
Yeah, I was just going to echo my appreciation and add a little bit that, without going into details, this was a big ordeal, a very serious ordeal, and working together there, Dr. Jones and Chief and Sean and all of us, Dr. Jones and his staff, along with Chief, they provided peace of mind for this family, but more importantly, they probably saved this person's life, which is, that's why we're here. So, there's always, usually you don't hear anything but the bad stuff. Sometimes you don't feel like you're supported, probably from members of this body, but thank you, because you made a huge difference in that family, and you do it every day without broadcasting it for everyone to know, so we appreciate you.
thank you. have to give credit to our staff. They worked very hard, and we engaged a lot of people, and they got to work. So our staff's to be given credit for that.
Okay, Counselor Deere.
I just want to get some clarification on, people that have been vaccinated with the Pfizer or the Moderna. I've had some friends that have come down with COVID, and they were told they only need to isolate for 10 days and then back out. But originally it was what, 14? Is there any variance or anything with that, or?
I would say there still needs to be some testing around that, engaged in that, but yes, they've changed the rules a little bit on us, and those things change weekly sometimes. Sometimes we'll get a recommendation from CDC, and then the next week it's a little different. I will tell you that this is a case study, and I won't say any names or anything, but we had a husband and wife that that work with us. The wife doesn't, the husband does. He was vaccinated, she wasn't. They both got the Delta variant contracted it. He had about what was equivalent to a runny nose for about 3 days. She was in the hospital. So the vaccine does work, and it does keep you out. It doesn't keep you from getting it. There's still going to be cases where they're going to get the COVID, but it does keep you out of the hospital. It does keep you from that illness turning severe, and that's what we've seen. Usually, like I said, we've got 94% of the people that are, 95% of the people that are in the hospital right now don't have the vaccine. So, but to answer your question, those numbers change, and yes, I believe that's the correct number at this point in time. It could change next week, but yes.
And they said some of them were getting like slight headaches and that'd be it, but they were more of a carrier to the people that were unvaccinated.
Yeah, and the thing is, the viral load doesn't get as heavy, so you're not as contagious as what we're finding, and sometimes, it's harder to detect if you don't have a high viral load when you test. So we have had some situations that I know of where someone has been vaccinated and they've tested negative, and then at the at 3 days, and then at 7 days they tested positive. So I think the viral load is much lower, and so the chances of spreading it is much lower.
And the last part of that question is, when they did when you got COVID the first time, you had to wait 3 months to do it. Is that still the same rules?
That's my
If they get COVID
understanding.
last week, they need to wait after those 10 or 14 days and wait 3 months before they can get the vaccine?
Yes, and the recommendation is to wait, but they're also saying if you want to go ahead and proceed with it, you can.
Okay.
It's not going to hurt you to proceed with it earlier, but there is some. The recommendation to the physicians is to wait. I think it's 90 days. Yeah.
Okay. All right. Thank you.
Yeah.
Counselor Vasquez.
Thank you. Dr. Jones, what, if any, is there, or what benefit is there for someone that has had COVID to get the vaccine? Because I've had people saying they're not going to get it if they've already had the illness.
So what we found out, what we're finding out, I guess, is that your normal immunity will wane. And I can tell you from my own personal experience, I had COVID really early on. Didn't know that's what I had thought I had bronchitis, and we had a machine that we were calibrating in our lab, and they needed some volunteers to donate blood to get calibrated, and found out I had the antibody from having COVID. So Dr. Mara thought it'd be a good idea to have me tested every month to see how long the antibody would stay normally before I got vaccinated, and we did that as kind of a quasi-surveillance experiment, I guess. It stayed for 10 months, and at 10 months I lost the antibody. That was my normal immunity, and according to him, that was a little longer. They said 6 months was the average, and then I got vaccinated. So, but what I've been hearing and hearing on the news is that the immunity from the vaccine is longer lasting than our normal immunity. Again, we don't have the time frame on that to confirm that, because we haven't had the vaccine long enough. And so, but time will tell.
Thank you. Thank you, Chair.
Counselor Coates?
I am dismayed to hear about the lack of bed space, and I have the same question that I had for Mr. Valier is, do you know what the numbers of those that are hospitalized right now are children under 12?
So we
Okay.
have had some children that have come to us. We do not have a PICU, a pediatric ICU, or a NICU, neonatal ICU. We don't have either one of those. So we have had to transfer those children out. I don't know the exact number, but I do know that when we have our report, we do talk about things like that. And when one of the questions that comes up, have we had any kids? And we have. I'm told that the pediatric ICU over in Fayetteville is full. And I'm assuming that, we don't have a lot, but the ones that we have had so far, we've been able to find a bed for. It's a little less, a little easier to find. I don't say easier. We have been fortunate to find a bed for them. I don't know what that's like right now.
And to me, in my mind, this is kind of related. You were also talking about not as contagious, I believe, if I was understanding you correctly, when vaccinated, but with this Delta variant, even people who are vaccinated are more contagious than they were
With the other one,
with the
absolutely.
other. I mean,
Absolutely.
significantly more
Yeah.
contagious, if I understand correctly.
That is true. The viral load is less, and what I'm talking about is the amount of virus that's replicating is less, but this variant is more highly contagious. So even with the less viral load, the contagiousness is still very high. I think the last paper that I read was two. If you were in a room and two people would get exposed in the Delta variant, it's 4. So it's twice as contagious under the same circumstances.
And those are the two pieces of information that I put together in my own mind as to why I'm not in contact much with children, but I am in contact with people who are. And with the level of transmissibility, as I'm understanding of this one, I think it's very good for all of us to be much more careful than we have been perhaps for the past couple of months or since we got vaccinated or whatever, because this is the thing that hurts for me if I were to ever find out that I was in some way, shape, or form, related to the hospitalization of a child in particular with this, because.
And we are gearing up because school starts this week for most of our communities. And, our team is meeting collectively just about every day. And the topic of discussion is what is going to come the next 3 to 4 weeks with schools opening up. It's a little scary for us right now.
Yeah.
We don't know what's around the corner.
I also want to thank you for your response recently. I didn't have a situation anywhere near what it sounds like the Adair County counselors had, but I had a question, and Dr. Montgomery did respond to it, and then you got back to me afterwards, and I do appreciate that very much.
Sure.
I think I was confusing terminology, so this is my last thing that I want to understand better. I think I was saying autoimmune, and what I meant to say was immunocompromised.
Okay.
And I am seeing different things about people who are immunocompromised. I have a good friend who is on immunosuppressants, I guess they're called, for another medical condition, who has been advised by her doctor, do not get vaccinated. I've seen other medical advice that says no, immunocompromised people can be vaccinated, should be vaccinated. Can you offer any enlightenment on?
I would rather let Dr. Montgomery speak to that. That's kind of in his field, and he's been keeping up with all the latest on he and Dr. Mira. And so let me get you an answer from them if you don't mind, and I'll have them send you a response to that.
Okay, I really appreciate it. Thank
Sure.
you.
Speaker Byrd?
Go ahead.
Dr. Jones, you mentioned that our vaccination rate is about 70% for employees.
Yeah.
Have we attempted to advocate for more vaccination out in the rural areas through some type of mail like we do on the Disco magazine? Have we done anything like that to reach those people out there in the rural areas? Because surely with what we have technology-wise, we know the people that are not vaccinated.
We have worked through our public health department to have community health educators or have been working in the communities. We've taken surveys of what is making people hesitant and tried to overcome those things. We've had events where we've gone out and did vaccine at different places where people were gathering. We have
What about mail-outs?
Mail-outs, I don't know that we've done mail-outs. I think we did do, we did have a grant that allowed us to do a mail-out on, recently. So, yeah, I believe we did do a mail-out telling people about vaccine, about, testing. So, we have shifted some of our, focus away from testing to vaccine, and now we're shifting back. So,
Sure.
but we've worked with Howard and his group to identify leaders in communities to try to encourage the uptake. And what we found is the most valuable thing is when their provider, when they have their provider meet with them for some type of medical, dental, whatever visit in healthcare, when they talk to them one-on-one, that's the most effective way to get someone to get vaccinated.
Sure.
So we've made it available through all of our different clinics, through ER, through urgent care, that if you want to be vaccinated that day, we get you vaccinated. So we're making it as easy as we can for as many people as we can. Unfortunately, right now with the surge, we're having to pull people back that we normally send out to work inpatient or in our clinics. So we're not going to have the ability to do outreaches like we have previously simply because of staffing. We're running very thin on staffing, so unfortunately.
If we were put a map of the 14 counties on a wall, would we know where the pockets are that are not vaccinated?
We have a hot map that we've been using that they've generated to help us identify those areas that are less vaccinated than others, yes.
The reason I say that, one of the stronger advocates, of course, are the 17 members that you're looking at right now.
Absolutely.
When they make a recommendation out in the communities, most of the time our constituents will listen to that versus probably most medical people. I hate to say that, but,
Yeah.
they probably would listen. But anyway, it sounds like we're really going above and beyond. I just want to commend you and your staff for doing such an excellent job. I'll get with Howard later and see how many of those 2,000 speakers have been vaccinated, and we'll get those numbers later. But I just want to thank you for an outstanding job.
Thank you.
Okay, Counselor Lake.
Dr. Jones, I have a constituent, well, actually, it's his wife. She's an RN. She's got her master's in health administration. She's worked on the COVID unit at Mercy Hospital for the last 2 years, doing the ventilator, the infusions and all that. Now her contract's up. And we visited, and she would like to come to work for us, but she's non-Cherokee. Is that something that you would entertain? If so, I could get you her contact information.
Yeah, we have numerous job openings in nursing right now. So, yeah, all she'd have to do would be to look on our website and pick where she wants to go, because we probably have an opening there. We have a lot of nursing opportunities right now.
Okay.
It's really, as George said, it's a very competitive field out there right now, and there's a lot of what we call headhunters, people coming in and offering people big bonuses to quit their job and come work as traveling nurses or as contract nurses, and it's difficult because it's hard to compete with that right now.
Counselor Buzzard?
Dr. Jones, appreciate all the answers you've given about the virus. Since this is my last meeting, and I ask these questions and bring them to your attention because they're concerning to me and concerning to our patients that use our clinics. And I just want to give you a list of things that that I want you to be aware of. And to the next counselor takes my position, I hope that they stay on top of this to make sure that we get it done, because everything I ask you is because I'm trying to help our citizens. And I think that's what you're in the job to, is help citizens. So I'm going to ask you some things and just let you know. I brought it up last month is about the mammogram machine at the J Clinic. We don't have one right now, so I understand we're in the process of maybe getting something like that done. So hopefully we do get that done in the future.
Okay.
The other thing is about the parking lot at the J Clinic. I brought this up before because if anybody's ever visited there before, they know it's a big, long walk. And I do understand that the patient can call in there to get assistance out to the parking lot if they need it. But most Indian folks don't ask for a lot of things like that. They try to do it on their own. What I'd suggest that we do is when we pull up around to go to the front doors, have a phone or a speaker system to where they can ask for that help. I just had a patient recently that could not walk unless they had a walker, and they just couldn't make it to the clinic, to the door. So if you would check on that, I would appreciate it. The other thing is the TVs in the clinic up there. I had some citizens ask me why we don't have the TVs in there, and I think we talked about this before, and it was something about the technology part of it. But if you would take a look at that and see if we could get them, because a lot of them are sitting there and they'd like to see what's happening down at the Cherokee Nation at our headquarters. And I know a lot of that stuff is put on the TV, so they would appreciate that. The other thing is, I'd had a question, and I didn't bring it up last committee meeting, is our Gadugi Clinic over here. How many patients do we see on an average day? Do you have any idea what that is?
I don't have that off the top of my head. It's more of an urgent care situation, so as patients need it, it's there for them to go to rather than having to drive up to, or as employees need it, I should say, rather than having to drive to the clinic. So it's more of an urgent care, and with that type of thing, it's hard to predict how many patient visits you're going to have. Now, I do know they do follow-ups, and they do schedule follow-up appointments if someone needs one. So, but I don't have those numbers off the top of my head. Yeah.
And I guess the reason I asked that question is we have a doctor on staff over there and have an RN on staff and have other people on staff. And I'm wondering if they're utilized to the most potential of what they could be is what my question was. So until we know that, we're not going to know. Other than that, it's been a pleasure working with you, and I think you've always answered my question. Dr. Montgomery has been an excellent person to call for contact. So thank you for your time, and thank you for helping our Cherokee people.
You're welcome.
Thank you.
And I will tell you, we do have numbers on Gadugi. I just don't have them here. But we do keep numbers on everything. So we know if the staffing needs to increase or decrease by the number of visits that they have. Right now, we have extended that we are doing testing for employees over at Gadugi Clinic now. So if someone here is exposed or comes to work and they're not feeling well, then we're doing the testing there. So we're making it as convenient as we can.
Okay. Then I do have one more thing that I'd like for you to check on. It's at the J Clinic, Sam Hyder Clinic. I've been told that if they have a code red and the doctors and nurses are back at their stations, they don't have a exit to come right straight out to the front. What they have to do is go back around to primary care, out the hallway, then back up front. When the clinic was designed, if I remember right, it was supposed to have been a hallway or a doorway to where those providers could come directly to the front part of the office, to the building.
Okay.
So if you check into that, I think it could be remedied yet, but Lord help us if somebody needed it there and 30 seconds made the difference on the thing. But if you would look into that, I would appreciate that also. But thank you, and it's been a pleasure working with you.
Thank
Thank
you,
you, Madam Chair.
Counselor Smith?
What's the furthest we've sent somebody away, do you know? We've had to ship out?
I don't know the answer to that. I know there have been some that we've shipped quite a ways.
Have we shipped some to Denver?
It's possible. I can't tell you that exactly, but it's possible. We've had, right now, there are no beds in Oklahoma. That's what we had last night. I read the morning report every day for the last 24 hours, and we had a situation, and that's why we have 6 people sitting in the ER right now waiting for transfers or waiting for a bed. We had they called 40 different transfer coordinators and could not find a bed.
And I've had 2 calls on people that their kids have tested positive. And if they have to go to the hospital and everything, and they're young, how does that work with the 2 parents? Only one get to go, or how does that
You're
go?
talking about to visit, as a visitor, as a guardian, yes. They are allowed 1 visitor, 1 guardian, yes.
And they'll stay in there the whole time, like if they're young like that?
Yeah.
Okay. One more. What should be our answer when the elders call us and ask about the booster? What do you want us to tell them?
We haven't got any definitive information on that yet. Now, Israel is kind of ahead of everybody else, ahead of the curve, because they were very proactive in getting the vaccine out, and it looks like they are going to be recommending a booster to everyone over the age of 65 and vulnerable. So you kind of watch what they're doing to anticipate what we'll be doing, and I would suspect that we will have a booster, but we have no definitive information on that yet.
Okay, thank you.
Thank you. Counselor Shambaugh.
I might have been out of the room when you addressed this, but are surgeries like, let's just say like a rotator cuff, the non-emergency, non-life or death, are those surgeries now being canceled due to the higher strains that the COVID is putting on, those type of surgeries?
Yes, we have elective surgeries have been pulled back. We're evaluating it every 2 weeks, watching the numbers, and then as soon as we see the numbers coming down where we can absolutely have a bed available if someone should need it after a surgery, then we'll start surgeries back up. Now, emergency surgeries are being done anyway. So if you come in and you have to have an emergency appendectomy or something like that, then that's going to get done. But elective surgeries that you can schedule out are being pulled back temporarily until we can ensure that we have bed capacity.
Okay. I just had a couple of calls, and I told him I assumed that's probably what was happening, so thank you, sir.
Okay, Counselor No Fire.
I noticed that you had said a minute ago, there's no beds in Oklahoma, period, right now, correct?
That's what we've been told by our ER staff.
What's our bed occupation percentage right now that we're at? Are we at full capacity too?
We're at full capacity.
How many more new beds have we established in the past 12 months?
Let me go back to my notes. So we've gone from, currently we're in the first stage of our surge. We have gone from 6 ICU beds to 14 and step downs from 3 to 4. Med-surg beds don't change because those require a room. We have
Right.
25 med-surg beds, and we have 25 med-surg beds now. And then we are holding patients in our ER when we can. Our next phase is to go to another area of the hospital that we'll be moving beds into. Unfortunately, staffing is limiting us to doing that at this time.
Oh, wow, okay. I'm trying to, I'm sure it's a big, difficult step to try to add more beds, I guess.
It's not just putting a bed in a room. There's monitoring devices and all kinds of equipment that goes along with it, and then the staffing that goes along with the higher level of, high acuity of care. So our limiting factor right now is not space and equipment, it's staff.
Is there, I guess it's kind of a crazy question, but this is, a whole new era for everybody. Is it better to have someone in a hospital room in a bed with limited monitoring because we have limited staff than to be at home with no monitoring at all?
Well, if it's somebody that needs to be in the hospital, they're going to be held until we can find a transfer for them. We're not going to send them home if they are needing care or needing to be monitored. That would be a violation of our ability to, we have certain laws that we have to follow, and if someone presents to us with a situation that they need care, then we're going to do everything we can to care for that person.
So what's our biggest hurdle on hiring more staff, though, so we can get these additional beds? And I guess the other thing is, do we already have the products to have more beds? Like, do we already have more beds and more monitors and stuff so we can establish them as soon as we have more staff?
We were proactive with some of our funding that we got early on to buy more beds and monitors and be ready for things like this, but it's hard to anticipate the workforce environment, and as everyone knows, it's nursing. There's a shortage of nurses anyway, and we've got everybody competing for the same resource right now.
So we're short on nurses, but we're not shortage on nurse practitioners, right?
There's a lot of nurse practitioners out there looking for work, yes.
That, is there a way we could maybe open doors up to have more nurse practitioners in, so that way we could possibly utilize those? I'm just trying to brainstorm
They
ideas.
have to be willing to work at that level,
Right,
and most of them are not.
right. Even if we paid them for the level that they should be at?
They're willing to work at that licensure level.
Okay, so we wouldn't pay them for their nurse practitioner level and just say, hey, right now, we just need you on staff to take care of these people who are sick that we don't have beds for.
And there's a lot of, we've talked about that, and we've had we do have some RN, nurse practitioners working at RN capacity, but there's not a lot willing to do that.
Okay, all right. That was just my thing. I was like, well, if we have a few $billion, we need more beds and we need more staffing, how can we, if we gotta pay people more to do less work, but they're qualified to do, just to take care of those people while we have this huge surge, I'm all for it, so.
We're working with staffing agencies. We're trying things outside the box. We're trying everything we can possibly to get the staffing.
Okay.
The staffing agencies are all competing against one another also, so.
Right.
There's a limited resource out there, and everybody's vying for the same resource.
Gotcha. Appreciate it. Thank you.
Yeah.
Anybody else with any questions? Okay, Dr. Jones, I have a question. How many beds do we have in how many beds are in recovery, and then how many surgery operating tables do we have?
Our ORs, we currently have 4 that are functioning. And what was the first part of that?
Recovery? How many
In
beds are in recovery?
In step down or?
Step down, well, you can call it step down, I call it recovery.
Units. I don't know the number off the top of my head, but if we do have surgeries, they go there before they go somewhere else. Is that what you're asking, the PACU?
Yes.
Post-operative surgical beds?
Yes,
Yeah.
are those beds counted in the numbers you gave us earlier?
No.
You know, actually, a nurse could recover a patient in the surgery suite itself, and that would free you up with those other beds.
Well,
For additional beds.
The problem is, we still have labor delivery. We still have all those other things going on. We still have people who have emergencies that come up. We have people who still have heart attack, all the things that go along with that. So we can't tie our ORs up with that in case we should have emergency C-section or something of that nature. So we have to leave those rooms available for that. And again, we still have emergency surgeries that are going on
Right,
every
right.
day. It's just it's a balancing act and a shell game right now, moving people around.
Well, worst case scenario, you could tie up 1 or 2 of those operating room beds post-surgically to be recovered by a nurse. Maybe even a surgery nurse that rotated the case could recover that patient until they're safe enough to go to another unit.
Right.
That would just free up maybe 1 or 2 more beds. Listen, do we need to do something on the staffing and for your nurses? Do we need to offer incentive pay, give a pay hike?
We've worked on different types of things that we can do, and then we've worked through our staffing agency on things that we can do. It's really a difficult environment. Sometimes it's not just about the money. It's about working a couple of days a week and only working a couple of days a week because the money has gone up so high. It's really a crazy market right now.
So
Without
you're-
getting into a lot of detail, it's something we are fighting every single day.
So is our salary levels at the top of the chart, I hope?
Our levels are competitive prior to this last surge, and now we're looking at ways to be more creative so we can be more competitive. We're a little faster reacting through our staffing agencies. We have a little bit faster reaction time, so we're able to work a little faster through them.
Very good, very good. Anybody else with any questions for Dr. Jones? Okay. Dr. Jones, Councilor Coates.
I got one. Could you give those 2 phone numbers again on the hotline and the crisis?
Sure. The COVID hotline is 1-539-234-4030. And to schedule a vaccine, it's 1-539-234-4099.
Thank you.
Okay?
Okay, and Councilor Coates?
Yeah, thank you. It's just kind of an observation that I wondered if I'm headed in the right direction in my thinking, and I'm listening to you talk about the staffing levels and the difficulty and, the competitive aspect of all of this, and it just occurs to me that this is just another indication of the disparities in healthcare in our country, in that we are talking about a rural system that treats Indian people. Would it be fair to say that that's part of the lack of appeal, perhaps, in some of the competitive nature of staffing?
I think that there obviously is other markets that are able to be faster to pivot and be creative. We're working on some incentive programs right now. We haven't announced them yet. We're hoping to get that wrapped up today and tomorrow, that will incentivize some of our internal people to pick up extra shifts. But on the flip side of that, this is a very stressful time, and to pick up extra shifts is a weight on their mental capacity also, and we don't want someone to work themselves into a situation where they're not functioning at a high level. So it's a balancing act, and the market is different. Even though we're as close as we are to Tulsa market, we're still competing with Tulsa market. We're still competing with Oklahoma City market. So it does create a little bit of a problem.
Yeah. And I want to say, Councilor Shaw and I had a virtual town hall on COVID with Dr. Gann and Ms. Pivick and Mr. Enlow last week. And I was surprised because for the first time when I sent out an announcement of it, I received belligerent responses to it. And I made the statement to Dr. Gann and Ms. Pivick in particular, and that I'm sure they, our healthcare staff hear some amount of that. And so I just really want to echo what you were saying earlier, the appreciation that I know every one of us feels for everything that they are going through and that they endure through all of this. I just feel so much for them, and I'm so grateful for the dedication that they show every day. Thank you all.
Thank you. I'll pass that along.
One time, okay, Counselor Shambaugh.
I'll be short. Gosh, looking back when we were talking months ago and this was overseas and we didn't even know if it was coming or, and we were trying to prepare for what was coming, and then it got here and it hit us hard, and you guys have had to shoot from the hip a lot, and you've tried to figure out how to stay one step ahead or even try to keep up. Well, then you throw into the mix of people the competitiveness of hospitals competing for, faculty. I mean, those things couldn't even be seen. I mean, who would have thought that this would turn into all of this? And you guys have done a good job. I mean, you really have. And this is so difficult to predict on what's going to happen, but you guys have tried to stay in front. You've done what you can, and I think this council, anything that you've asked to help, we've all been supportive of that, and we appreciate you. But I just wanted to say that if you look from the start to where we are now, who would ever thought we would be doing what we were doing and having the problems and from different areas that we probably didn't even think of. So, again, thank you for staying on top of this and keeping our people safe.
You're welcome. Thank you. I will say, another thing about the nursing, that I didn't mention is we have an aging nursing workforce, and so a lot of nurses are retiring, and this is the thing that's pushed them over the edge. This is the thing, getting through the first surge, a lot hung on, and now we're hitting this second surge, and they're like, I'm done. I'm going to go ahead and retire. And you don't account for some of that type of turnover. You lose some of your more experienced, seasoned nurses, and those are the ones you're depending on training up your new nurses in a lot of ways. So it is difficult in this environment, and you can appreciate that they've gone through a long battle, and we saw it starting to taper down, and now it's ramping back up, and everybody's a little bit. It's a little hard on morale when you see that starting to ramp back up, especially when you have so many people, as you said, that come in our clinics and they don't want to wear their masks, they don't want to get vaccinated, they think it's all political hype, and it's a tough environment right now for healthcare. Tough environment. We feel like we're caught in the middle.
Well, you've done a good job. Thank you, sir.
Thank you.
Dr. Jones, this is my last meeting, and I want to thank you for all your support and working so closely with council. I'd also like to thank Dr. Montgomery for the medical staff. You all have just been extraordinary. You know, I was once in charge of a triage, just a trial run, and people have no idea. I mean, at deciding in something like this, the amount of planning and effort, and then actually, you know, going through with the situation, it's really something that's huge, and they have done it so wonderfully. I mean, I've said they ought to write a book on what they have done, and I hope you all really, really understand. We're talking life and death here. We're talking medical. Life and death. It's that important with what they're dealing with. And we have these healthcare heroes. I hope you do extend our thanks to them, because, my goodness, how would you like to send your daughter right out of nursing school into a situation where she could die? I mean, think about it. Would you want her to put on that mask and go care for that patient? These are truly heroes in this situation, and they deserve our support any way we can help them. But I do want to thank you so much, and I would implore council in the future not to lose a CEO because of politics. You know, when you're talking about life and death, that's so much more important than whether or not you get along, or they didn't return a phone call, or they didn't fix a sidewalk or a building or something. It's healthcare, it's people's lives, and I would implore you to always keep that in mind. This is my last meeting, and that's so important. But Dr. Jones, you've stepped in and you have exceeded all expectations, and I'm really proud of the work you've done. Thank you so much from the bottom of my heart.
Thank you. Thank you. And again, couldn't do it without our people. I mean, we
This
have
is true.
tremendous, hardworking, dedicated people that sacrifice every day.
Well, when you're averaging over 1 million patient visits a year, I've got to tell you what, and then what 2 or 3 we get as a headache phone call maybe we don't want to deal with. Let me tell you, that's a drop in the bucket to what you're dealing with, and we're all so appreciative. Thank you so much.
Thank you.
Okay, is there any other business, any old business, any new business? Next meeting is Monday, September 13th at 1 p.m. I'll take a motion to adjourn. Second?